In this episode of Idea City.
How many of you have been on a jet airliner in the last 6 months? How many? Okay, year, everybody, right? Would you have ever got on that airplane if that pilot hadn't actually practiced landing in Toronto in every weather condition possible? Not a chance. Yet, tomorrow a patient will subject himself to surgery in my hands without me practicing his surgery. The more a surgeon does a procedure, the better they are at it. The more circumstances they've seen.
Idea City, the smartest people, the biggest ideas.
Stephen's going to talk, I think, about more practical matters, and in particular, the applications of these ideas to medicine and to, I guess, the instruction of therapies. Yes? All right. Stephen Pautler.
Thank you very much for having me here, and Moses and his wonderful team. I am going to bring much of what we've heard into the context of human care and care of patients, and some of the things that we've been doing just down the 401 in London. So the surgeon extraordinaire to Queen Victoria, Erickson, said, well, you know, realistically, we've done it all. We can't do any more. And in the 1870s, 1880s, it was thought that surgery had reached its end point. The barber surgeons from Henry VIII day had bled people to death, and that was all. We're done. Thankfully, this was not really correct. When we look, there were a lot of advancement. Sterile technique. Just over 100 years ago, most surgeons operated with their bare hands. Hands in the wound, patients died of sepsis. The concepts, and Lister taught us about bacteria and all of these fabulous microorganisms. The idea that we can actually invade the human body, do a task, repair it, really took a major leap when we learned we have to wash our hands. Okay, and guys, remember that when you go to the washroom, okay? I'm a urologist, I know where those have been. We've also become much better at choosing our patients. For the disease that I deal with the most, prostate cancer, we were horrible at picking patients to try to cure with surgery. Advancements in anesthesiology, imaging, all aspects of medicine have allowed us to really ride this revolution. When we look, minimally invasive surgery was the next logical step. You think about it, okay, you're cutting someone wide open, you're putting your hands in there, sure, you're taking out that prostate cancer, the kidney, the liver, whatever it is. The next step was, well, can we do this? Can we look into a human body without truly invading it in such an aggressive manner? How many of you in the audience have had surgery? I don't need hands, but or you can show your hands, okay? Many of you likely had surgery where you had to be cut open. The surgeon had to see what was going on in there. Well, minimally invasive surgery was now taking that the next step, placing a camera in the body to be able to take a look, somehow perform that task of surgery, using natural orifices. There's lots of them. Ronnie talked about some sphincters, you know. We have ways of getting into the body. Well, minimally invasive surgery was the next step. Keyhole surgery. How can we do the task minimizing the risk to the patient? When I trained, which is not that long ago, it was heresy to propose to do cancer surgery through small incisions. You would be ridiculed, the mentors would be, you're not doing the right operation, you're risking that patient, and you guys, you're gonna see 5 years from now, you're all, you know, you'll be strung up for doing this. Well, we've been able in the last 15 years to prove that we can minimize pain, get patients out of hospital faster, give them better cosmesis, and do as an efficient an operation, and sometimes better. So I think most people in the audience would pick a drug that, you take maybe once, ever. It cures your illness, whatever it is, your prostate cancer, and has zero side effects. Well, that pill doesn't exist. What about surgery? Would you submit to surgery knowing you're going to be cut open, you're going to potentially bleed, have a fair amount of pain, maybe incontinent the rest of your life, have erectile dysfunction? I won't ask for a show of hands for that. But in all seriousness, that's what patients are submitting themselves to every day currently. When we look, the prostate cancer story is one that affects everyone in this room, and I'll challenge you, for those of you who don't know someone or haven't personally had prostate cancer, you will. Your lifetime risk in Ontario is 1 in 6. So in the front row, you can just do the math. I'm one of 8 children. My third oldest brother, who just works down University Avenue, had prostate cancer age 51. So I actually have a vested interest in this. This is something that I have a personal interest. My risk is about 1 in 3 I'm going to get this disease. It's a huge burden. Now, we're well behind where the breast cancer movement is. Men, we don't talk about these things, it's kind of embarrassing. Every guy sees a urologist get on stage, they stay seated. I didn't see anyone get up, that's good. Moses ran away, did you notice that? The story goes that we really need to bring this to the forefront because of the burden of disease on our society. You look at the numbers, it doesn't kill every man who gets this disease, but we're better at diagnosing it earlier, we're better at treating this disease. You look, Frank Zappa is there. Frank Zappa died age 52, a premature death. Wonderful artist, a fabulous musician, and because of this disease that potentially could have been cured sooner.
When we come back,
Taken my hand and miniaturized it to 7 millimeters. That's what we're using. So this has really dramatically changed the way we're doing surgery.
get the latest Idealist news, presenter information, and watch streaming video at www.ideacityonline.com. Idea City, the smartest people, the biggest ideas.
When we look at minimally invasive surgery with respect to prostate cancer, taking the minimally invasive approach, putting the surgeon's eyes into the patient was attempted. These are the gurus in my field, and they said, hey, we're going to take this on. So they published this paper. This is when I was still in training, 1997. They published to say, hey, you can do it, but their conclusion read, it offers no advantage to open surgery. So this really basically destroyed this operation. It stopped much of the development of this operation. Thankfully, a few surgeons in France who didn't really like English literature or read it kept going, and they kept trying, and they were working, and within a year of this, they published 50 cases saying, hey, this is feasible. We can do it, and we're down to 4 hours, and it's not 10 hours like the American guys said, and this is worthwhile. Let's go forward. So the rest of us took note. We said, hey, this, the gurus say you can't, but these other guys say you can. Let's look at this. Now, technically, it's very demanding. You're working away for 3 or 4 hours. Your eyes are in the patient with the scope, but we're operating with chopsticks, basically, using instruments quite long. The engineers understand fully the fulcrum effect, where I put my little access into the body, determines what maneuvers I can do. So along comes some very bright engineers in California, really drawn from worldwide. They said, well, can we make this better? How do we improve a surgeon's ability? And the Robotic Revolution came. And basically that takes the surgeon's eyes inside the patient, and we heard about stereoscopic vision. You see in 3 dimensions. Standard minimally invasive surgery, we're operating 2-dimensional off a screen. Sure, I played a lot of video games during med school. I can probably do that pretty well, but in reality, seeing 3 dimensions, it really does help us. And it's taken my hand and miniaturized it to 7 millimeters. I don't know if you can get a shot of that with the camera, but that's what we're using. So this has really dramatically changed the way we're doing surgery. Now, again, there's all those other advantages you heard. We can measure things. We can follow the surgeon's eyes around, not just the face, but we can follow it around the abdomen or whatever area we're working. We have better dexterity, accuracy. The Starbucks coffee tremor is gone. So all of these things that are day-to-day for a surgeon, we can improve on. This can be better than we are physically capable. Sorry, warning, gory part. Basically, this is just showing a little video clip of me repairing a urinary tract after the prostate's gone. So I've removed the cancer, I'm sewing. Again, those are 7 millimeters in size. I'm sewing in a very small, tight space, 3-4 centimeters in size. To do this in open surgery, I'm almost standing on my head, but the interesting thing is, biology and humans are adaptable. And for 100 years, we've been doing it that way. Now we're able to do it with these very fine tools. When we look, in Canada, right now there's, as of the end of April, just over 1,000 cases done, and I've done a little more than a quarter of those. This technology is now infiltrating our Canadian healthcare system. And we're evaluating it in our system as a solution for Canadians. Is this something we can widely offer? Are we doing a better operation, and are we getting better outcomes? The problem is cost, and that's something I'll touch on in a moment. So when we look at robots in Canada, surgical robots, we have Montreal got the first one, London got the second and the third. Then there was a little explosion, 4 more came out. Montreal got another, Edmonton got a couple, and Vancouver. And then Toronto last year got 2 robots. So there's 9 machines in the country. Hopefully there will be more. The disparity comes with this slide. That's the United States. There's well over 400 robots in use in the United States. Part of this speaks to the differences in our healthcare systems and funding. Not being too political, but right now our government doesn't have a mechanism to evaluate surgical technologies and to infiltrate it into our healthcare system. A woman has breast cancer, has a receptor positivity, gets a drug called Herceptin, $10,000 a month. We don't deny that. In the province of Ontario, we have a well-defined mechanism for access to that expensive drug. But there's no mechanism for us to get access to expensive surgical technologies. And I'll speak to that in a moment. When we look, right now there are many disciplines of surgery using the robot. Urologists, we have the corner on the market for the most part, but the cardiac surgeons, the gynecologists, there's about 600,000 hysterectomies done in the United States per year. So that's a definite area that this technology will continue to advance in.
When we come back,
Canada realistically is a big country. Patients would rather die than travel to have surgery.
get the latest Idea City news instantly. Follow us on Twitter. Idea City, the smartest people, the biggest ideas.
When we look at how do we educate the next generation of surgeons, we have to look at other high-tech fields. And Boeing really had it correct. They said, well, if you read about it, you remember 10%. If you actually see someone show you some videos and pictures, you're going to remember about 30%. If you do it yourself, you're at 90% recall. So that is where the role of advanced surgical education comes in. And you saw the simulator, SimMan outside. That's where we're going. The dogma I was taught under was see one, do one, teach one. All of you have probably watched Grey's Anatomy or ER. That's, in some cases, reality, where, you're turned loose, away you go, practice. Well, could you imagine NASA saying that? Okay, guys, Dave Williams, get up in that space shuttle, fly up there, and go practice on the International Space Center. No, not a chance. They're way, way smarter than that. When we look, the operating room is not an efficient classroom. We really have minimal margin for error. Someone's life is in our hands. You look at preventable errors. You look at the actual increase in waiting lists. Academic health centers tend to have the longest waiting lists in the province. So there have to be better ways. Well, one way is simulation. And that's what Preston Manning was talking about yesterday, simulated parliament. Well, it works here in surgery. We're about 30 years behind the nuclear industry, space, but certainly I think we have the ability to make leaps and bounds, and the SimMan is one realm. When we look, a surgeon's experience and with a particular operation is critical. So this is one of my colleagues, that's inside the patient's heart. This was a patient operated on down in London last year. And it's a repair of a mitral valve. So he's in there with the robotic arms, working away. Well, Bob Keyhole, who's the surgeon in this case, very experienced, the most experienced in Canada doing this work. One of the most experienced in the world. But how did he get that experience? Well, he had to learn on people. So did I. And ethically, that's one of our big dilemmas. How do you go through that learning curve? And simulation is one of the answers that we have. The more a surgeon does a procedure, the better they are at it. The more circumstances they've seen. How many of you have been on a jet airliner in the last 6 months? How many? Okay, year, everybody, right? Would you have ever got on that airplane if that pilot hadn't actually practiced landing in Toronto in every weather condition possible? Not a chance. Yet, tomorrow a patient will subject himself to surgery in my hands without me practicing his surgery. Well, that's, I think, our next step. When we look, we've developed in London a multidisciplinary center of educators, of surgeons, of engineers. I get to talk to really smart people like Hod all day. And this center is designed to bring together all types so that we can develop better surgery, better technology, better education for our young surgeons. Another key component is partnering with industry. Looking and talking to guys. Get David there and we'll talk about some key features of what he's doing and sit down and try how do we make this better for humanity. And C-STAR is a facility that we're quite proud of. Eric Lindros actually donated $4 million so we could complete this center. Unfortunately, his head injuries stopped his hockey career early, but I think he still has enough insight that he's probably going to need healthcare in the future, so he donated some money, which was very kind. When we look, personalized surgery is one way we're going, where I have an MRI, I look at the ultrasound image, I fuse that with what I'm seeing in the robotic surgery, and I provide the best possible operation for that patient. All of which I practiced the night before on a really full stomach and good night's sleep and all of those things. The other important aspects will be telesurgery. And you've had previous speakers at ideacity talking about telesurgery. Rick Satava, who is a real forefather of surgery, gives a great talk about this, remote surgery. And Canada, realistically, is a big country. Patients would rather die than travel to have surgery. That's about 80% if you actually query them, tell them they have to travel 4 or 5 hours. They rather stay in their community and have a higher risk of a complication than travel to get the best possible care. So we need to take the surgeons to the patient. And then the miniaturization of robots, nanotechnology, I think is also coming down the pipeline. With that, I'd like to thank you all for your attention and thank Moses for the opportunity to be here.
Thank you. Thank you.
Yeah, I'm a rookie. It's my first time here, and I really am in awe of the other speakers and the global thinking that has come out of this. It made me definitely look at my own life and my own practice of medicine in a different way.